Okay, so now I used that case to describe for you or to illustrate for you the developmental step. Is you're looking at a kid, and I think the first step before you even get to OCD, get to the mental health issues, is you need to have a developmental context. You need to know what's going on developmentally and how much of what's going on with this child might represent developmental issues alone. Without that base, any sort of psychiatric or mental health evaluation is going to be very, very problematic. Now, step 2 is the psychiatric or the mental health component, is the assessment of that. So once one has done the developmental review, you can then launch into the assessment around the psychiatric issues. And for kids, and I'm going to focus on kids who are generally under school age, again, the primary culprits from the psychiatric perspective are going to be anxiety disorders, ADHD, and tic disorders. Mood disorders, maybe a little bit more in later adolescence are an issue, but it's, that neuropsychiatric triad. Issues with regards to differential diagnosis need to be addressed in terms of this. There are repetitive phenomena that occur in autism, the repetitive phenomena that occur in OCD, trying to figure out what is what, and what we can ascribe to what disorder is important. And I think also to really pay attention to the functional impact of these symptoms and the functional impact of the treatment or the lack thereof. So we're going to go through this by talking about another boy. And this is CJ, who's 13, and he has a history of social and learning challenges, and the school and the pediatrician are wondering about whether this boy also has an autism spectrum disorder. So CJ moved into this school district from another area of the province in grade 5, and the information that came with him at that point indicated there had been some concerns at the previous school about socialization, but generally he was meeting expectations. He needed some additional help and some practicing and reading and writing. And before he left the previous school, they did a reading screen test, and he was a little bit behind, about 1 grade level. Since coming to this new school, he's having more struggles keeping up and fitting in. So socially, he is described as a kid who's kind of isolated, often associated with another boy who's quote-unquote on the spectrum, which is always a telltale sign, is it? Not unless you put them in the same room force them. I mean, I hear this all the time. I just say this because it seems to be a tag, is that, well, his best friend's autistic, he must be. But in any case, he's not very successful socially. And in grade 6, he's barely meeting expectations in English and socials, or he's not meeting expectations in English, socials, and barely in math. So CJ gets referred to the school-based team. Several recommendations are made, including putting him on the list for psychoeducational assessment through the school district, and for the family to take him to a physician to get a review to rule out any potential quote-unquote medical causes for his difficulties. The school discovers there's at least a 12-month, perhaps 18-month backlog for psych ed testing, so they're not going to get that anytime quick. The other school district is much quicker. But in the interim, what the psychologist is able to do is some kind of a clinical review, which involves, the terminology on the province changes at different times, and in some places are using the term functional behavioral assessment, although it's not the same as a functional behavior analysis. But in any case, but it includes some clinical scales. Again, the BASC and the SASI, the screener is used, and lots of elevations on these scales. There's problems with conduct, problems with atypicality. These are just terms that we see referenced in these scales, which basically indicate that there's lots of issues going on. And the SASI, which is the autism screen that is used some places in this province, recommends that this kid is very much like kids with autism and should have multidisciplinary assessment for ASD, which doesn't exist in this province, by the way. In the fall, CJ, who's now 12, is seen by the pediatrician, who reviews the information from the family and the school. The family says, well, CJ's always had some difficulties. And in fact, when they were in the previous residence in grade 3, there were some issues at school. They went to see the pediatrician. They recall saying something about anxiety, but things kind of got better, and then they moved, and kind of things went underground, and there was no follow-up. When you probe a little bit more, you find out that as a young boy, CJ was very clingy, very cautious. They couldn't really get him to attend preschool when he was 3. And so that first year, he stayed at home. The second year of preschool, when he was 4, they managed to get him into there, but only in a parent participation preschool. So he didn't really want to separate that much. And in kindergarten, these issues happen again. Mom spends an extended period of time transitioning him into kindergarten, but he has a really good new young teacher who is very holding and mothering to him, and he feels a little bit safe, and it's a great situation because this is a K-1 split, so mom feels comfortable that this is going to be the same teacher, and he's going to get more comfortable, and he actually does not too bad. He's able to keep the same teacher, and for a couple of years he does reasonably well. When you ask about CJ at home, he's described as being generally pretty interactive with his immediate family, but always, they use the word shy. He's always been a bit shy. He never liked new social encounters, whether it was a family gathering, their annual family gatherings, or the after-school things that happen with his peers, and would make efforts to actually try to avoid some of those situations if possible. So when there was a big family Christmas dinner, CJ really didn't want to go to it, make some protests around it, and so forth. He is seen as social by his parents, but they say that they've done a lot of scaffolding. They've done a lot of prep work. They've done a lot of creating this, and really see that if they hadn't done all that stuff, and they don't do all that stuff, he'd be more and more isolated. He's always been pretty quiet, reluctant to talk outside the home, including at school and these family gatherings. In fact, sometimes when he was younger, there were times where he actually got pretty mute. At school, he's described as isolated, and they use the code words. He has pragmatic and social communication skill problems. He also has a history of some nighttime fears, and when you discover that it was actually 8 or 9 before he was actually able to sleep independently on his own. And now in the last couple of years, the parents are hearing more about him fretting about things. He's worrying about things. He's always kind of preoccupied with something. When the whole Ebola thing happened last summer, there was a huge panic, and he wanted the parents to buy all the safety suits and the masks and everything. So it was quite distinct that they were surprised at how anxious he became and how preoccupied he became. He's always been really fussy about his food, this kid. He doesn't like the way things, if they were touching on the plate, or if the gravy was a different color or smelled a little bit off. But last year he actually went through a phase where the parents used the term, he became a bit of a germaphobe. He was looking at the cutlery and checking it out, making sure that, no, this is not right, not sharing food, only specific utensils. But beyond that, don't get any history of any broader rituals or compulsive routines. In the pediatrician's office, CJ is pretty passive. He's quiet, kind of sits there, doesn't talk much, picks at his cuticles a bit. Basically, he doesn't get much out of him. Doesn't really talk or produce much interaction. So the pediatrician wonders about mental health issues given this profile, but also agrees that given some of these issues, an ASD could be present, and make concurrent referrals to both BC Autism Assessment Network and to Child and Youth Mental Health. Okay, so this provides me another opportunity to go back to my table here and talk to you a little bit and introduce you to anxiety disorders of childhood.